Happy afternoon, everyone. I cordially welcome you all to our GarbhaGudi Institute of Reproductive Health and Research. Myself, Darwin, Business Development. It's my honor to take over the platform for today's CME webinar. We proudly welcome you all, the speakers, doctors, and students who gathered virtually. General instructions, mobile phones on silent. For any queries, please drop it in the chat box or please interact during the interactive session. Let's begin today's CME with a great short note on the journey of GarbhaGudi. GarbhaGudi was founded in 2011, where our progressive work has led to the progression of implementation of the latest medical technologies, methods to overcome male and female infertility. GarbhaGudi IVF Center is known for its extraordinary and immense success rates, ethical treatment, affordable cost, with world-class infrastructure and human touch. Now, GarbhaGudi IVF Center is spanning over a decade, who is still serving as a ray of hope for thousands of infertile couples. Recently, GarbhaGudi IVF Center is awarded with Bangalore's fastest growing IVF center by Radio City and also ranked third for its best treatment in South India and 8th place across India. GarbhaGudi, which is a chain and new generation infertility treatment, hospitals equipped with state-of-the-art infrastructure and cutting-edge technologies like IVF, ICSI, PGD, etc. to address these ever-increasing infertility issues. With the backing of such a capable and strong organization on GGIRHR, the providing the foremost training to budding clinicians, embryologists, andrologists, and other staffs to mold them for the challenges of infertility treatment. GGIRHR is affiliated with Rajiv Gandhi University of Health Science for Fellowship in Reproductive Medicine, IMA-AMS for Fellowship in Infertility, Garden City University for Post-Graduation Diploma in Clinical Embryology. We also provide ultrasound scan course and other residential and non-residential fellowship, which is GGIRHR certified. Students at GGIRHR are trained with tips and tricks, procedures and protocols followed at GarbhaGudi IVF Center, which is art guided, has given unbelievable success rates. Now we're glad to inform you all that we have spread with 7 centers across Bangalore in serving thousands of infertile couples. Without further delay, let's begin today's CME. Our first speaker for the day is Dr. Shubha, who is a fertility specialist at GarbhaGudi IVF Center, Electronic City branch. She is a skilled professional, completely passionate about her job, and aims to provide the best treatment for her patients. She is well equipped with ART procedures. Today, Dr. Shubha is here to talk on genital TB in infertility and its treatment. Over to you, ma'am.
Thank you. Happy afternoon. I know it's a busy and hot day and it's a lunch timings, so I wouldn't make it boring. Let it make more interesting and interactive. So let's start with genital tuberculosis and infertility. Overview. We'll just introduce how is genital TB, causative organisms, pathology, pathogenesis, clinical features, diagnosis, treatment, and male genital TB. How and when did this female genital TB was introduced? It was recognized as clinical entity in 1000 BC, way back in 1000 BC basically. Morgagni postmortem, Morgagni postmortem examination of a woman in 1744 found her uterus and tubes were filled with gaseous material. He, who is Robert Koch, discovered tubercular bacilli way back in 1882. Coming to the incidence, hope I'm audible to everyone. Sorry for the voice. True incidence is not known. Approximately 5% of females with subfertility worldwide have genital TB. 68 to 89% of cases of genital TB in India were between 20 to 40 years age. So we can see here, I don't know whether the pointer can be seen here. So US is just 0.07%, Saudi is 4.2%, Scotland is 5.6%, and India being maximum, which is 19%. Causative organism, the Tuberculosis, occasionally it could be Mycobacterium bovis or Mycobacterium tuberculosis. Replicating cycle is 17 to 24 hours. Gram-positive bacillus, which is acid fast and alcohol fast, due to presence of mycolic acid, staining, Zn staining, and fluorescent dyes. I wouldn't go into the depth of it. Cultural characteristics. The bacilli growth, which is 4 to 8 weeks on solid medium and 1 to 3 weeks liquid medium. LJ medium is solid medium and bacteria is liquid medium. So pathogenesis, the genital TB is almost always secondary to TB elsewhere in the body. If bacilli not eradicated in the early stage, may get reactivated later in an immunocompromised status. So once the genital tract is colonized, the granuloma containing the viable tubercular bacilli are formed within various pelvic organs and then they develop into tubercular hypersensitivity. Clinically silent and the interval it can be 1 to 10 years or even longer. And then it reactivates and becomes the clinical manifestation. There are 3 modes of spread: hematogenous spread, lymphatic spread, and direct spread. Most important is hematogenous spread, where the most common and the most important affected in genital TB is the fallopian tube. It is 95 to 100% first is affected is fallopian tube. So the fallopian tube, the most favorable lead is with the earliest lesion in the mucosa. Uniform initial pelvic involvement of the tubes with subsequent dissemination to other organs and the peritoneum. The maximum and the most common in genital TB is the tubercular peritonitis. Lymphatic spread, it is usually from the abdominal cavity, and direct spread, it can involve to the bladder, rectum, appendix, and the intestines. So this is what which I had been already mentioned. So I don't know whether the pointer is again visible. So you can see on the right side picture wherein which the fallopian tube is 90 to 100%, uterus is 70%, ovaries are 30%, cervix 10%, vulva and vagina, which is least affected, is 1%. So coming to the tuberculosis of the fallopian tubes, which is the most common affected, you have tubercular endosalpingitis, which can be seen in the laparoscopic picture, which is placed in the right side. TB exosalpingitis, interstitial TB salpingitis, salpingitis isthmic nodosa. So the gross appearance varies and is non-diagnostic and also can appear normal or slightly edematous. Isthmus and adjacent interstitial portion may remain free of tuberculosis. As the process continues, the tubes become softer and caseation develop in the inner wall. At times, the peritoneal surface of the tubes will be studded with tubercles. And coming to the microscopy, which is caseous necrosis, liquefaction, and ulcer in the lumen. Adhesion of the individual foci may result in the large cystic spaces, pseudofollicular salpingitis. And again, there are too many things which I don't want to go into the depth of the pathology. What is more important here is in chronic tubercular salpingitis, unless multiple sections are taken, the characteristic lesion may be missed. Coming to the endometrium, the gross, most extensive in the fundus and decreases towards the cervix. Myometrium is usually not affected. Extensive involvement means it could be ulcerative, granular, fungative lesions. Microscopic features, again, I wouldn't go because it will be in the pathology side. So coming to the ovaries, it is usually the bilateral involvement, 2 forms of ovarian TB, which could be periophoritis or oophoриtis. And this is again by hematological spread. Coming to the cervix, which is 10% common, no specific macroscopic changes. It can be appearing normal or inflamed, resembling invasive carcinoma, most common type being ulcerative form. Peritonitis, 2 varieties, serous variety and the plastic variety. Most common is serous variety, wherein which fever, ascites, weight loss, and anorexia. The other variety, plastic, which is less common, we have dullness, doggy feeling, and the tenderness. And the other, all pelvic organs are densely matted together with tubercles studded in the peritoneal surface, foci of caseation and calcified plaques, which represent attempts of healing. Peritoneal fluid is exudative with a predominance of lymphocytes. Remember, why is it exudative? It's all because when you take an ascitic fluid for aspiration, in case this could be an exudative. In peritonitis, tubercular adenitis, the mesenteric or the pelvic lymph node, generalized military peritoneal TB. Such superficial lesions do not usually impair the reproductive functions of the pelvic organs. So this is the symptoms. Most important, it can start from oligomenorrhea, amenorrhea till it can reach to menorrhagia when it is affected with TB endometrium. Differential diagnosis of TB endometrium could be pyometra, and it could be irregular, it could be uterine leiomyoma, fibroid adenomyosis. There could be irregular menstruations. It could be abdominal vaginal discharge. The discharge it could be foul smelling, which can be synchronizing with a CA, that is carcinoma. TB vulva, which can be representing like a tumor, but the signs can be bloodstained discharge in the ovary because it is an hematogenous spread, which is periophoritis. So it can present as tubo-ovarian mass in the scan. TB fallopian tube, it can be present as ectopic pregnancy or the tubal block or the infertility. TB pelvic, which can result in the fistula formation or the malaise. So the rupture of the tubercular pyosalpines, pelvic inflammatory disease, all could be synchronous, or it could be a differential diagnosis when it comes to TB. First important of TB is infertility. Menstrual disturbances, which I've already mentioned, it can range from oligomenorrhea, amenorrhea till menorrhagia. And when it comes to the other organs, it could be abdominal swelling, postcoital bleeding, vaginal discharge, and dyspareunia. Remember, these are the important symptoms which is being mentioned in the quick way. Clinical diagnosis, high index of suspicion, where 20% given by family history, 30 to 50% might have some form of tuberculosis with history of ATT. And sometimes it could be just unexplained infertility. Chronic PID refractory to standard antibiotic therapy. Coming to the infertility, which has been related to the genital TB. Infertility is very common in female genital TB, which could be ranging from 40 to 80% and can be both primary and secondary. First, as tubal factors, it can definitely block the fallopian tubes. It could be unilateral or bilateral. Loss of tubal function due to ciliary damage, causing infertility and ectopic gestation. Perisalpingitis, meaning the outer part causing adhesions and tubo-ovarian mass formation. Again, it could be hematogenous spread, wherein which ovary is being affected and the other pelvic organs are affected so that the adhesions are formed. Tubercular hydrosalpinx with or without obstruction. When it comes to ovary, when it is involved, due to TO mass formation, adhesions and ovulation and poor ovarian reserve, there could be infertility issues and ovary, the oocyte functionality and the quality will be hampered. Endocrine disruption can happen, chronic anovulation, Mycobacterium tuberculosis as anti-gonadotropic effect. So the mycobacteria inhibit the basal production of progesterone and antagonize the stimulatory effect of HCG on corpus luteum, causing a LPD, implantation failure, lower pregnancy rates, and higher miscarriage rates. The poor embryo quality due to intrinsic oocyte factor defect. So the harmful interleukins, it could be 6, 8, 10, induced by immune modulation or by direct effect of toxins of mycobacterium, adversely affect the oocyte development within the follicle. So when it comes to the endometrial receptivity, which are essential to make the endometrium receptive for embryonic implantation, it can adversely affect an endometrial markers and also the caseous or fibrocaseous of endometrium lesion causing Asherman syndrome. Most important and the commonest symptom and sign seen in the endometrium when it is related to genital TB is Asherman's or adhesions. So the endometrial atrophy and synechial formation is definitely seen in genital TB. What does vascularization happen to endometrium when it is affected? So the activation of anti-phospholipid antibodies in the endometrium, meaning the immunity is being just lost there. So the reduced subendometrial blood flow due to the involvement of the basal layer of the endometrium and also through immunomodulation with the production of enzyme procoagulase causing vascular thrombus formation. So investigations, these are the investigations which can be helpful for diagnosing genital TB. HSG, USG, laparoscopy, histopathology, laparoscopy meaning histoscopy, also histolaparoscopy, microbiology, chest X-ray, and hematology. So we'll see each one of us how does it help and diagnose for genital TB. So hysterosalpingography is contraindicated. Remember, it is contraindicated in the presence of recent acute pelvic infection. So uterine cavity is classically striped and deformed with associated intrauterine adhesions and lymphatic extravasation. This is the one which can be seen here again. The first picture is intravasation of the type. Rigid pipe stem, we can see here there is the fallopian tubes is just not visible properly. bilateral corneal block, wherein which we can see just the uterus, the right and the left, which can't be seen. And this is the one which hydrosalpinx and tubular uterine cavity, where the cavity itself is hampered. And this is one of the other pictures. This is the picture of terminal sacculation are seen in both the tubes. And on B, where there is irregular multiple filling defects. And C, there is complete obliteration of the uterine cavity due to extensive synechiae. So you can see here, there are various HSG films which can just be seen in genital TB. Here is one more, wherein which it is T-shaped configuration. You can exactly clearly see in HSG film where it is a T-shaped and there is a rigid pipe in the tubes. And in B, it is again because of the DES exposure, which was way back in 1880s. So it is T-shaped, and this is a Netter syndrome, wherein which it is obliteration of the entire uterine cavity due to extensive synechiae formation, giving the glover finger appearance. When you place a glove finger, that is how it is being visible. So the obliteration can be clearly seen. When it comes to ultrasonography, when we do scan, it will be definitely a thin endometrium persistently. It can be starting from day 1 to the end of the period, the end of the before they could come for the periods also on day 27, day 28 also. The endometrium will not go ahead of 7 mm. So that is one of the persistent finding in tuberculosis. And this is the endometrium hardly is 2 to 3 mm. Endometrium lining appears broken, bright, and echogenic. And this is one of the periovarian inflammation and specks of calcification on ovarian surface. See, here also we can see this is the Asherman syndrome, whereas the destruction of the basal layer of endometrium, resulting in scarring and bands of scar tissue. See, here it could be because of the infections of tuberculosis, or it could be because of the vigorous curettage or DNCs. This is one of the other pictures of the scan finding, wherein which it is patchy endometrium, hyperechogenic bridges within the uterine cavity, and HSG can help us to know the reduction in the endometrial cavity. This is one more picture. Coming to the hydrosalpinx, this is thickened longitudinal folds of fallopian tube. The folds produce a characteristic cogwheel. This is the cogwheel which can be seen here. You can see the specks when it is in the transverse section appear when imaged in the cross section. And this is one more significant finding seen in the ultrasound, wherein which this beads on string or waist circumference, waist sign can be seen, which facilitates discrimination between the hydrosalpinx and the other adnexal masses. It's a poor vascularization on Doppler. 3D images will be far better helpful rather than 2D images. Coming to the hysteroscopy, there is no appearance which can be described as diagnosed of tuberculosis. This is the various hysteroscopic findings. It can range from periosteal fibrosis, pale endometrium, micropolyp, endometrium tubercle, intrauterine adhesions. This is focal hyperemia, diffuse hyperemia, polyp again, caseation, shrunken cavity. So this all varieties can be seen on hysteroscope. So the nature of intrauterine synechiae associated with tuberculosis are dense and cohesive. Findings: appropriate cleavage plane during hysteroscopic lysis may prove to be technically difficult with unavoidable myometrial damage and uterine perforation and can occur. So even if the cavity is restored, synechiae reformation rate is quietly high. So this is the laparoscopic findings. Again, coming to this is the various laparoscopic findings which can be seen. Hydrosalpinx, tubo-ovarian adhesions, beaded tubes, edematous tubes, tuber diverticula, agglutination, rigid tubes, and many others. So the confirmation findings, the clear evidence is multiple granulomas or exudates, loculated fluid or adhesions, hydrosalpinx or beaded blocked tubes. What could be suspicious? Patent tubes with pelvic congestion, few scattered small granuloma, fimbrial agglutination and phimosis, tubal sacculations, mild adhesions, and straw-colored fluid in POD, periheptic adhesions. Diagnosis. Coming to the latent TB infection diagnosis, it could be Montex tuberculin skin test or interferon gamma release assay, which is IGRHR. Quantiferon TB or quantiferon gold detection of release of interferon gamma on stimulation of sensitized T cells by Mycobacterium tuberculosis antigens, the T-spot detection of T-cell tercels. So this is a Montes text technique. Hope everyone know this. A standard dose of 5 tubercular units is injected intradermally and read the findings 48 to 72 hours later. So a discrete plane elevation which can be seen in the picture here on the second picture. So a discrete pale elevation of the skin 6 to 10 mm in diameter should be produced when the injection is given correctly. So the olar aspect of the left forearm is the preferred site of the test. So why do we do this? So it tells us it is delayed hypersensitivity reaction. T cells sensitized to by prior infection are recruited to the skin site where they release lymphokines. So if it is more than 5 mm, 10 mm or 15 mm. So if it's more than 5 mm, it could be positive in HIV positive person, recent contacts of active tuberculosis cases or persons with nodular or fibrotic changes on chest X-ray, consistent with odd elite tuberculosis or organ transplant recipients or other immunocompromised patients or end-stage renal disease. If it's more than 10 mm, then it is recent arrivals or less than 5 years from high prevalence countries, injectable drug users, mycobacteriology lab personnel, children less than 4 years of age, infants, children, adolescents exposed to adults in high risk categories. But if it is more than 15 mm, then persons with no risk factors for TB, sensitivity is 50%, specificity is 80%. So false positive, false negative will be definitely there. Coming to the quantiferon TB gold, wherein which plasma from whole blood is incubated with Mycobacterium tuberculosis, specific antigens ES86, RD1, CFP10, and the levels of interferon gamma. Interferon is measured. So the positive test meaning the point more than 0.35 international units per ml. So the good corroboration with PCR diagnosis, monitoring of response to ATT in women with latent GTT. Sensitivity is 89%, specificity is 98%. So active disease, clinical suspicion, response to the treatment, AFB staining, AFB culture, nucleic acid amplification, histopathology, and chest radiography. What does menstrual blood help us? So on day 1, day 2, when the menstrual blood is taken, so we can check for AFB culture, Ziehl-Neelsen staining, carbonyl fusion, Oramin, Rhodamin, stains bind to mycolic acid of the cell wall. It requires 10 organisms per ml for a positive test. AFB culture, which is a solid culture, egg-based LJ, and other things which is already known. Sensitivity is 80 to 93%. Specificity is 98%. BACTEC 460 is radiometric semi-automatic technique. Detection of carbon dioxide liberated during the growth and decarboxylation of the C-label surface incorporated in the growth medium. So the detection is 8 to 14 days as compared to 3 to 5 weeks on solid medium. The disadvantage being the use of C-labeled radioactive substrate. It requires strict regulations of handling and waste disposal of radioactive material. Coming to the MGIT, that is Mycobacteria Growth Indicator 2, which is non-radiometric and offers the same rapid, sensitive, and reliable methods of testing as the BACTEC system. So it yields the results in 8 days, other things which can be known. Molecular diagnosis, it is PCR, gene amplification test, which is gene probe, mycotuberculosis, direct test, and Roche amplifier mycobacterium tuberculosis test. PCR may be positive in presence of as low as 1 to 10 organisms per ml. Nested PCR, RT-PCR, real time. So PCR, the viable mycobacteria, there is plasma DNA, 16 is single strand RNA and mRNA. So the other things can be known. So the nucleic acid amplification assays detect mycobacteria with high specificity by amplifying target nucleic acid sequences. Two direct NAT tests are gene probe mycotuberculosis direct test, Roche amplifier mycobacterium tuberculosis test. This is the sensitivity, which is 84 to 100%. Specificity is 98 to 100%. Positive predictive value is 90 to 100%. So the gene expert, which is a simplified molecular testing, fully automating the 3 processes, real-time PCR-based molecular testing. Expert MTB or RF is an automated diagnostic test that can detect MTB and resistance to rifaximin. So evaluation of the diagnostic procedures, smear, histopathology, culture, PCR. So Remember, the culture PCR is sensitivity is 100%, specificity is 100%, positive predictive value and negative predictive value is 100%. So these are the various papers which has been published. Most important and most common papers which you can just go through is Sharma. Dr. Sharma is the person from AIMS who has variously written on genital TB in India. Complete hemogram may show anemia, leukocytosis with lymphocytosis and raised ECR in TB, but it is non-specific. Chest X-ray, posterior anterior film should be performed to exclude or confirm coexisting respiratory TB or old stigma or previous pulmonary TB. But remember, if the patient is trying for pregnancy, so chest X-ray should be usually avoided. But when it is active TB, then it can't be avoided. So this is the one. Now, the guidelines have been already changed from 2010. So the genital TB, it has 6 months treatment, wherein which the first month will be given and then the later. So this is the one revised one. TB patients are classified into 2 groups, namely previously treated based on the history. New is 2 HRZE plus 4 HRE. Treated one is 2 S plus HRZE3, 1 HRZE and 5 HR. Relapse of failure. So this is the drugs which has been mentioned in the RNTCP. This is the, remember, this is the categories which we have to really know when we are dealing for the female patients. So the isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin. So with the adverse effects, dose, everything has to be. This is the AKT kit which can be seen here. So ethambutol, isoniazid after dinner, pyrazinamide after lunch and the rifampicin after dinner. So which has been already mentioned. So the before starting AKT, blood investigations, liver profile, renal profile, ophthalmic checkup, including fundoscopy. After starting AKT, liver profile every 2 weeks into 2 months, then every 2 months into 6 months. Renal profile after 2 weeks, then every 2 months. Ophthalmic checkup every 2 months into 8 months. What should be the surgical treatment in case failure to conceive even after full 6 months of ATT? Laparoscopy and hysteroscopy may be repeated to see any remaining diseases. Tuboplasty after ATT, not much help. Chances of flare-up of the disease and risk of ectopic pregnancy. So the surgical treatment, despite adequate therapy, then it is persistent or recurrent disease, recurrent pelvic masses, recurrent pelvic pain and AUB, non-healing fistula, concomitant neoplast. How do we deal with these patients in IVF when it is female genital TB? Poor prognosis for fertility in spite of ATT, low conception rate that is 19 to 20%, still lower birth rate that is 7%. IVF pregnancies can lead to 16% per transfer. So the IVF embryo transfer has been found to be most successful out of all ART modalities in genital TB patients with 17% of conception rate, in contrast to only 4% with fertility enhancing surgeries. So the latent genital TB has been found responsible for repeated IVF failure in Indian patients presenting with unexplained infertility with apparently normal pelvic and non-endometrial tubal factors. The pregnancy rates and take-home baby rate could be improved by early detection when there is minimal damage and aggressive management of the disease. This is the reasons why there could be the poor result with IVF in female genital TB. Most patients are poor responders, need higher starting and maintenance dose of gonadotropins. Endometrium invariably is poorly developed and even exogenous estrogen may not help. Oocyte and embryo quality is definitely poor and pregnancy rates are poor. So in post-ATT treatment, IVF is better so that it will help in receptivity of the endometrium and also shrunken small uterine cavity with Asherman's adoption or gestational surrogacy is advised. Indications for surrogacy: moderate to severe intrauterine adhesions or Asherman syndrome, not amenable to hysteroscopic adhesiolysis. Atrophy of the basal layer of endometrium, not responding to the hormonal therapy. Basically, we track the endometrium depending on the HRT and place. And when endometrium doesn't grow more than 6 mm, that is when we know that these patients, the endometrium receptivity is really less. So the grossly reduced endometrium thickness less than 7 mm in spite of estrogen supplementation with high resistance subendometrial blood flow in the proliferative phase is the one where you can advise for cervix. Or the same as dense pelvic adhesions, and also unexplained repeated IVF failure with endometrium showing persistence of TB granuloma or PCR positivity despite adequate antitubercular chemotherapy. Coming to the male genital, which is very rare, that is 30 to 40% of extrapulmonary TB. So urotract, kidneys, ureter, bladder, and then urethra. So when it comes to genital, epididymis is the most common. Then is the prostate, vas deferens, seminal vesicles, ejaculatory ducts, and the last is the testis. So anatomical obstruction due to caseous necrosis and granuloma formation. Distortion of normal anatomy by inflammation. Modes could be descending, intracanalicular, or hematogenous. Management is the same as this similar. Here, what we do in particular is microsurgical reconstruction for anatomical obstruction, transurethral resection, and marsupialization of the dilated portions of the ducts into urethra. Testis is usually spared. Testicular sperms are almost always available for aspiration. The one of the interesting case wherein which 29 years old Mrs. A and 35 years Mr. B married for 7 years. So with previous one left ectopic pregnancy, medically managed, so came to us for with secondary infertility of 5 years. On evaluation, CBC was normal. TSH was 4.2, HbA1c was 5.6, and other investigations were within a normal limits. Histolaparoscopy was done, revealed right tubal block, left tubal delayed spill, beaded appearance of both the tubes. So after obtaining consent from the husband, bilateral tubal ligation was done. TB PCR of endometrium was positive, so we treated for 6 months. IVF was planned. So then they had a conception after 2 cycles of IVF. So one more, wherein which 38 years, married for 5 years, presented to OPD with history of primary infertility with ASO. So on detailed examination, he had pulmonary TB and took AKT for 6 months, 2 years ago. So no other significant history. Azoospermia, FSH was 5.2, INIVEN was 188. Other investigations where 5 chromosome deletion was absent, karyotype was normal. So trial PESA was done and showed multiple and plenty of motile sperms, which and then frozen and then used for eggs. Thank you.
Thank you so much, ma'am. Thank you for your talk. It was an absolute delight. Thank you so much, ma'am. Our second speaker for the day is Dr. Pavithra, a fertility specialist. Before that, if you have any queries, doctors and students, you can ask Dr. Shubha ma'am for the discussion. If no doubts, we can continue for the second speaker. Our second speaker for the day is Dr. Pavithra, a fertility specialist, well versed in the latest advanced in ART, including procedures like IVF and IUI. Dr. Pavithra, here to talk on luteal pace defect. Over to you, ma'am. Dr. Pavithra will be joining in another 2 minutes. There is a question. What is the different stages you seek into treatment? Can you please elaborate the question briefly?
We have received a question saying, how would you treat genital TB infertility? See, basically, in genital TB, first thing is you need to know the history. History is most important, and most of them, when they marry, most of the female side of the family wouldn't even mention that they have been affected. So history is definitely important. Second thing is investigations. And when you do a scan, that is when you detect that this patient could be affected with genital TB. Third is the blood investigations, where ESR will be definitely high. Lymphocytes will be definitely high. And also, if the diagnosis, if you are being suspicious that this patient could be giving a history, it could be PID, it could be white discharge, it could be irregular cycles, oligomenorrhea, amenorrhea, or menorrhagia, or there could be a small TO mass which has been in the history when there is a childhood history. So this is all which can be suspicious, telling that it could be genital TB. That is when you ask, and then you can call up on day 2 for them, day 2, and take that menstrual blood and send for the TB PCR and also histopathology. That is when you can directly detect TB PCR AFB culture. So this is one of the things. Second thing is, and also you will get to know the ovarian reserve If the age is around 25 and the reserve is just 3 and 4 follicles, that also you can just think. And relating to it, endometrium, when it is very thin and she has come at around day 20, day 25, she is not a PCO patient. She is not obese, she is very lean. And then also you have to suspect, because if the endometrium is less than 7 mm on day 20 also, why should the endometrium be so thin? Ask about the cycle in particular. Ask about oligomenorrhea, amenorrhea, cycle regularity, which will definitely give you a clue of tuberculosis. And also make sure she is completely treated ATT for 6 months. Repeat the whole blood investigations, chest x-ray, making sure that everything is settled, and then so 6 months later again take a break of 3 months and then start the treatment. So before you could give an IVF option or any others, check for the endometrium tracking. So give an HRT therapy of estrogen therapy so that you can see the endometrium lining, whether it is coming, the receptivity is it being good, and also the blood flow is good. डॉक्टर शोभा has asked, मैम एक पेशेंट है जिसका प्रेगनेंसी कंसेप्शन में प्रॉब्लम है, one tube block and other one side is ovarian cyst. So this first thing is whether this one is definitely a tuberculosis, genital tuberculosis has to be seen first. Please mention us the history. What is is it primary infertility or secondary infertility? What is the married life? How is the semen analysis of the husband? This all will help us and tell us. And single test to diagnose genital TB for low social group. One thing is gene expert is the good test. If that is not possible, then at least take the menstrual blood on day 2 or day 3, sent for AFB culture and TB PCR. Thank you, everyone. I can understand where the resources are very less and the physicians do not treat. So please attach them to the RN TCP so that they will definitely help you. And endometrium culture positive TB PCR, make sure you treat them properly for at least 6 to 9 months and then help them. And best options would be, if there is adhesions or pelvic adhesions or Asherman syndrome, please don't suggest them for further treatment of IVF. Go ahead for surrogacy and help them for a better and a neat cycles of IVF. And thanks, Sandy, for mentioning us. Thank you. Very good and elaborative talk.
Thank you so much, Shubha ma'am, for answering all the questions. And our next speaker, Dr. Pavithra ma'am, over to you.
Hi. Hello, everyone. So today my topic is luteal phase support. Am I audible?
You're audible, ma'am.
So today's topic will be discussed under these headings. That is the introduction, luteal phase defect, luteal phase support, definition, indication, drugs which we use in the luteal phase support, and what is the best timing for the support and how long to give the support. So coming to the introduction, successful implantation will require the synchrony, which is between the competent blastocyst and a receptive secretory phase endometrium. Luteal phase is defined as the period which is present between the ovulation and onset of menses or establishment of a pregnancy. In natural cycles, luteal phase is characterized by secretion of the steroid hormones like estradiol and progesterone from the corpus luteum, which itself is supported by the LH of the pituitary gland. So coming to the follicular phase and the luteal phase. So what happens in the follicular phase is, so the estrogen, that is, it starts to rise during the follicular phase when the follicle gets selected and it starts to get big. That follicle basically contains a lot of estrogen. So this dominant follicle, definitely it has more of estrogen. And with that, what happens? The mid-cycle, that is the LH will start to peak. So this LH peaking would stimulate the ovulation. So the ovulation process occurs because of the LH surge. So, and one more very important thing is pulsatile LH secretion. So not the constant, but it should be in a pulsatile manner. That basically stimulates the corpus luteum to produce more progesterone, which basically induces the endometrial secretory transformation and promotes the receptivity. So coming to the way the corpus luteum is formed. So basically you have the Graafian follicle, which base contains all the cells, that is the granulosa cells, the theca cells, the theca interna, externa, the antrum, which is filled with the follicular fluid, and the cells which becomes the corona radiata, and that is after the ovulation. So what happens to these cells is they become luteinized. So the granulosa cells will enlarge, the theca cells will become luteinized theca cells, and they differentiate, and the basal lamina that itself gets dissolute, and there is rapid vascularization. So basically it becomes very nutritious. So that is how a mature corpus luteum looks. Then coming to the role of LH in the luteal phase. So is the role of LH very important? Definitely, yes. So what is the responsibility of this LH? So one thing is the steroidogenic activity of the corpus luteum, that is the estrogen and progesterone in a correct ratio. Then coming to the upregulation, that is of the growth factors. So mainly that would be the vascular endothelial growth factor, then fibroblast growth factor 2. Then coming to upregulation of the cytokines. So these cytokines are involved in the implantation. So basically making the endometrium more receptive, and also stimulation of the LH receptors in the endometrium, again leading to a secretory endometrium, which is more receptive to the embryo. So coming to the role of progesterone. So what does this progesterone do? Basically, it changes the endometrium, that is the follicular proliferative endometrium becomes secretory endometrium in the luteal phase. So the progesterone deficiency, it will basically delay the endometrial maturation. So there are studies which say that when you remove this corpus luteal cyst, that is before the pregnancy reaches 7 weeks, it can lead to pregnancy loss. And also in a normal pregnancy, which was having this progesterone, when you remove this corpus luteal cyst, that time when you give progesterone from outside, then this normal pregnancy can be maintained also. So mainly progesterone is important for the pregnancy maintenance. Then coming to what is this luteal phase defect? So it's a condition in which the endogenous progesterone, which is produced in our own body, becomes insufficient to maintain a functional secretory endometrium. So this thereby hampers the normal embryo implantation and also the growth of the embryo. The result of this either deficient secretion or suboptimal response of the endometrium to normal progesterone secretion. So there's a difference. One is the body is decreased production of progesterone. That is because corpus luteum is some defect is there, or the endometrium also could be not responding to the progesterone which is already being secreted. So coming to the pathophysiology. So what is this pathophysiology? When you see this luteal phase defect, how all can it occur? So one thing is when there is any receptor, fault in the receptor. So what are the receptors at fault? It could be the LH or the FSH receptors. And because of that, the folliculogenesis itself does not happen properly. So when the follicle itself is not building up properly, maybe the estrogen environment is not good enough, the follicle is not a good mature follicle, what happens? It results in a deficient corpus luteum. So because of that dysfunction, the corpus luteum may produce less progesterone. And other functions can also deplete this process. That is, it could be because of the abnormal FSH and LH. So the levels in the body itself, so the FSH might be very high during the follicular phase, or the LH itself could be very high, and it would have not been suppressed properly. So that way the follicle gets disturbed. Apart from that, it could result from a clinical condition like hyperprolactinemia or a thyroid disorder. So these things, again, because of the hormonal imbalance, it would result in a dysfunction of the corpus luteum, thereby causing the endometrium, which is not being prepared properly. And also it could be related to the fault in the E2 progesterone receptors as well. So all these problems will lead to what? Infertility, or sometimes the pregnancy may occur, the implantation may occur, but it will not support the growth of the embryo, leading to recurrent miscarriage. So luteal phase defects in a non-stimulated cycle, that is in an ovulation induction where we give timed intercourse, or in case of an IUI, these kind of patients, whether or not this luteal phase support is required. So what does the evidence say? So coming to clomiphene citrate, what happens with clomiphene citrate? Markedly, the clomiphene citrate has high luteal E2 levels with abnormal E2P4 ratio, glandular stromal dyssynchrony, luteolytic effect on corpora lutea, and anti-estrogenic effect on the endometrium. So when we come to CC, let's go to the basics. So what happens in this CC is that, what does it do basically? How is the mode of action? It occupies the hypothalamic site. So when it occupies the hypothalamic site, what does it do? It starts to reduce the LH levels and also the imbalance. It creates an imbalance in the estradiol and the P4 concentration. So which will affect what? The endometrial receptivity. And this anti-estrogenic effect which it causes, that also affects the endometrium. And to overcome all this, we give the luteal phase support, but empirically. So this is not evidence-based, because evidence says that in natural cycles or CC stimulated cycles, we do not require luteal phase supports, but we give it empirically so as to support these findings which we see in the clinical, in clinical practice, what we see. So we give empirically to even the stimulated cases. When you come to lectros, so what happens in lectros? There is low E2 levels in the initial follicular phase, and there is a receptor upregulation. There is no effect on production of progesterone, thus the lower luteal E2P4 ratio. So coming to GT. So gonadotrophins, do we give? Definitely we give. Why? Because gonadotrophins giving, why do we give gonadotrophins? To get a follicular response. So when the patients don't respond with CC or lectros, we give a gonadotrophin to boost the response, but it may result in one or more follicles. So because of that, there is some change which is happening. So to regularize that, there will definitely be a luteal phase defect. So for that, to combat that, we give the luteal phase support. So when you see the peri and post-ovulatory period, the endometrium itself would be advanced. So the maturation of the endometrium seems to be more advanced. And also the frequent glandular and stromal dyssynchrony is also there in the mid and the late luteal phase, according to the studies. So the endometrial advancement is most seen in the high responders, which again will impair the uterine receptivity. So coming to causes. So in a natural cycle also, there could be a luteal defect. So how do we know about it is one thing, the cycle. The cycle regularity is very important. Even if it's a natural cycle, even if the cycle, the patient has a regular cycle, if it is a short cycle, and when we monitor them post-ovulation, the luteal phase itself is very short, then these patients require a luteal phase support. So basically, it could be the disordered folliculogenesis, defective corpus luteal function, abnormal luteal rescue by the early pregnancy, and a variety of other clinical conditions like previously also discussed, hyperprolactinemia, hyperandrogenic state, then weight loss, stress, athletic training. This may not result in oligo or anovulation, but it manifests as a luteal phase defect. So is there any diagnostic criteria for inadequate luteal function? So methods proposed for this luteal phase defect is one of the home tests which patient can monitor themselves would be the basal body temperature, but whether this helps them is definitely questionable, because mainly it is inaccurate, and basal body temperature has to be measured first thing in the morning without doing any work, as in get up in the morning, check the temperature. So it gets very inconvenient. So most of the time patients also get discouraged because the values don't seem to tally up. Coming to basic tests, which will definitely be, diagnosed, would be the serum progesterone levels. So serum progesterone, usually in a regular cycle, we check on the day 21. In irregular cycles, we check it weekly basis also. If it is negative, again, we check after a week and so on and so forth, to know whether the rise in progesterone is happening, whether ovulation has happened, and to know the defect, if there is any luteal phase defect. Coming to endometrial biopsy, would be a definite diagnosing criteria, but it is invasive. We cannot do it practically for all cycles. nor even for just 1 or 2 cycles, because it is an invasive procedure. Unless it is required, we don't do it for luteal phase defect as such. TVS, again, yes, it does give us an idea about how thick the endometrium becomes. But again, secretory changes, maybe we will be able to see because of the homogeneous, echogenicity of the endometrium in the scan. But it is more relative also. It depends on how the patient is following up also. It should be a regular followed up patient, because then only we'll be able to calculate the number of days of the luteal phase. And coming to ovulation and adequate luteal length, one more thing at home which some of the patients do is this urinary LH surge detection and monitoring of the luteal length. So that again, they say it is around 90 to 95% it is detecting the LH surge, but the test also is quite expensive. And apart from that, it is not very reliable compared to that of a scan or the blood test. That is by doing the serum progesterone levels. So coming to the sonographic criteria. So what do we see in this ultrasound is, so before the follicle ruptures, if the follicle is less than 17 mm, so we call it as the follicle has not become mature enough and it has already ruptured. So that could also be something to look into the folliculogenesis, or it could be a poorly formed or an ill-defined dominant follicle. Luteinized unruptured follicle. Sometimes even after trigger, the follicle fails to rupture. So there could be an inherent defect in the ovulation process itself. And sometimes the lutein cyst starts to form. And sometimes corpus luteum itself is absent. And also the lack of endometrial echogenicity on 7th post-ovulatory date. So these are the things which we see for a luteal phase defect. So how do you define this luteal phase defect in a natural cycle? So now we are more into the values. So coming to the mid-luteal progesterone levels, if it is less than 10 nanograms per ml. If mid-luteal progesterone levels do not always reflect the endometrial maturity, that is also there. Most reasonable consensus is a lack of more than 2 days in the endometrial histological development compared to the expected day of the cycle. But again, this would be invasive. So currently, there is no reproducible pathophysiologically relevant and clinically practical standard to diagnose luteal phase defect and distinguish fertile from infertile women. The roles of this basal body temperature, urinary LH detection kits, luteal progesterone levels, endometrial biopsy, and other diagnostic studies have not been established. And performance of these tests cannot be recommended, because either ways, the progesterone has been released. At least if you have tried for the pregnancy, there is a way to look into it, but it delays the further time. Instead, we could just give the luteal phase as empirical, and maybe the pregnancy sustains. So coming to luteal phase defect in all stimulated cycles. So here is a schematic representation where you see the graph. One is showing the hyperstimulated cycle and the other one is showing the normal cycle. So if you see the hyperstimulated cycle, the luteal phase length is short compared to that of the normal cycle. So this is again proving the point that there is a luteal phase defect in a stimulated cycle. So coming to an endometrial biopsy on the day of ovulation in a natural cycle, here we are not seeing the secretory features. And here is a clear secretory features which are seen in case of the oocyte retrieval day. That is when we are giving the stimulated cycles where GnRH agonist and gonadotropin stimulated cycle. So we could see that it is kind of advanced. On the day of ovulation itself, secretory changes are already present. So coming to luteal phase support. So when it comes to luteal phase support, there are a variety of drugs which we use. So we will get into the details in the coming slides. So the term which is used to administer these medications with the aim to support the process of implantation, that is only called this luteal phase support. So how would we go about it? First approach would be correction of any underlying condition, hypothalamic or thyroid. So mainly any clinical practice, what do we do? Once we evaluate the patient, we definitely check for their prolactin levels and their thyroid levels. So why is this important? Because if there is any abnormality, that itself could be the reason why they are having the recurrent pregnancy loss or why they are not conceiving itself. Then coming to the second approach, that is empirically treat. And then Coming to promote the endometrial maturation, enhance the receptivity, support the implantation and development of an early pregnancy. So who all require this luteal phase support? Confirmed cases of luteal phase defect. So already we have some cases where we have confirmed it. So these patients we should not we should always give them the support. Unexplained infertility, advanced reproductive age, ART techniques like when we are going ahead with the gonadotropin stimulated IUI or an IVF or an XC. Then coming to hyperprolactinemia, all downregulated cycles, recurrent pregnancy loss, PCOS, and thyroid disorders. So what are the drugs which are used for the luteal phase support? So it's progesterone, HCG, GnRH agonist, estrogen, heparin, prednisolone, sildenafil, and aspirin. These are again the adjuvants. Coming to progesterone, what is the mode of action? So this progesterone, how does it improve the chances of the implantation or even the endometrial receptivity? So basically, when we give the progesterone and we do not give the progesterone, the changes and the studies tell us that giving progesterone will improve the endometrial receptivity. It promotes the local vasodilatation and uterine muscular quiescence by inducing the nitric oxide synthesis in the decidua. It also acts as immunologic suppressant, blocking the helper T1 and inducing release of the helper T2 cytokines. So progesterone, what are the types? So we have micronized progesterone, 17-hydroxyprogesterone, dihydrotestosterone, capronate, and dihydrogesterone. And we give it orally, vaginally, rectally, parenteral, and intramuscular, and even subcutaneous. So coming to the vaginal progesterone. Targeted drug therapy, we can call it. Why? Because the target organ is very close to the vagina. So what is the target organ? The uterus. So the anatomy of the vagina. So when you see the anatomy, the vagina is rich with vascular plexus. So that provides an environment for absorbing these drugs. And also the rugae which this vagina has, it increases the total available surface area as well. And also the vascular system which is around the vagina and the venous drainage, all that basically does not pass through the liver. So we have this, we are bypassing the first pass hepatic effect. So when we avoid that, what happens? This vaginal progesterone does not create high concentration of metabolites, and because of that, we don't get much of the side effects of it. And also the bioavailability is also greater compared to the orally or any other form of progesterone. And with this consistent levels, it can even remain there for about 48 hours compared to that of the oral. And also the uterus is the one which utilizes this mechanism. And so because of that, again, the adverse effects is minimal. So coming to the vaginal progesterone. So when we apply this vaginal progesterone, see how it basically gets diffused into the entire uterus. So 1 hour after application and look at the reaction after 4 hours. So definitely there is a progressive diffusion of the progesterone from the cervix to the fundus of the uterus. So coming to vaginal progesterone, explanation would be that the passive diffusion happens, that is from the vaginal tissue to the uterine tissue, then passage through the cervical lumen from vagina to uterus, then absorption through the venous or the lymphatic systems, and countercurrent transport of this progesterone from the vaginal veins to the uterine arteries. So what would be the advantages? So advantage would be that it is very effective. It is convenient. That is, the patient itself gets self-administer, and it's also acceptable by most of the patients. And you get a high concentration of the uterine progesterone with low serum levels, so that you combat it with the low side effects. But disadvantage would be that it sometimes get accumulated like a cheesy material, which looks like a yeast infection. And some people may have some reactions, like they can have itching and erythema. So in those cases, we may need to use the other forms of progesterone. So coming to vaginal progesterones, micronized progesterone capsules. So what is the dosage which we give is 300 to 600 mg over 2 to 3 doses per day. This is according to the ASRM 2030. And vaginal progesterone pessary is also there, which the dosage is around 400 to 800 over 3 to 4 dosage per day. Definitely, evidence plays a very important role. So I've put upon the systematic review, which tells us how efficient this vaginal progesterone is for a luteal phase support in case of ART. So which vaginal preparation to be used? So in when you see this vaginal progesterone preparations, we have this Crinone gel, Cyclogest, Lutegest, Utrogestane, vaginal, which were found to be equally safe and effective vaginal progesterone products for luteal phase support in case of ART cycles. So what is this Crinone gel? So this is basically a formulated gel which has an inert base which attaches to and combines with the vaginal epithelium. This provides its extended duration of action. Crinone gel comes in the concentration of 1.125 grams, that is 8%, and it contains 90 mg micronized progesterone in an emulsion system, once daily administration. So what are the advantages would be? It has a longer half-life, lower patient-to-patient variability in absorption. That is, some people have even administered twice, but we don't see much of a difference. Since cost-wise it's quite expensive, better to give it once a day when it is effective once a day itself. Disadvantage, again, as I told you, the cost is very expensive. So one capsule cost is like 4 times that of the gel. I mean, the gel cost is 4 times that of the capsule. However, the base material is not absorbed, and some women accumulate into a cheesy material and they confuse it for the yeast infection. So they think it is a discharge and try to treat it. But as such, only if it is associated with pruritus or erythema, we need to give any antimonelian therapy. So coming to progesterone rings. So this is a form of progesterone which is impregnated into rings, and these supply continuously. And basically they keep, it will be like a sustained release where 10 to 20 nanomoles or per liter of progesterone is basically getting released daily up to 90 days. It is beneficial in donor egg cycles. So there are many RCTs where pregnancy rates were also high with vaginal as well as compared with that of intramuscular. And the vaginal rings, that is weekly rings, are effective and safe alternative for the luteal supplementation in IVF. This is also an evidence-based study. So this is how this vaginal ring looks, and this is how it is inserted and placed just in front of the cervix. So coming to oral micronized progesterone. So this one has a higher first pass metabolism. Bioavailability is quite low, that is only 10%. Micronization decreases the particle size and shortens this dissolution according to this equation of Noyes-Whitney. Side effects would be sedation and it's like an anxiolytic. Clinical trials of oral supplementation confirm the inadequacy of this route, where these women, they had a lower pregnancy and implantation rate and a higher miscarriage rate than those who took this vaginal or intramuscular. So we don't really use this oral micronized progesterone. So coming to the luteal phase support after ovulation induction and IUI. So this is a systematic review and meta-analysis where they have calculated, they have evaluated the effect of progesterone for luteal phase support after ovulation induction and IUI. So patients who are undergoing were the ones which were included, that is OI, IUI. So intervention was, some patients were given luteal phase support and the others were not. And in terms of outcome, it was seeing the live birth rate. So they included around 11 RCTs and some 2,842 patients and around 4,655 cycles. So what they concluded was that this support is beneficial to the patients who are getting treated, that is with ovulation induction with GT in IUIs. So ovulation induction with gonadotrophins in IUI cycles only had a benefit. So that anyways, we know that evidence-based is only for gonadotropin stimulated cycles, but empirically we give for the CC or the letro cycles as well. So coming to intramuscular progesterone injections, oil-based injections. So this is something which has a higher peak and longer lasting plasma concentrations compared to that of the aqueous. So progesterone, basically it's in an oil formulated with sesame oil and 10% of benzyl alcohol, which serves as its preservative. The only side effect is that it causes a lot of pain and hardness to the skin, very difficult to self-administer because of the pain itself. And it may cause, sometimes it causes even allergy and inflammation and even a sterile abscess. So this is how the progesterone injection looks. So this is the progesterone, which is 50 mg, and this is given deep IM. And coming to subcutaneous progesterone injections. So this has been a game changer for those patients who are allergic to the IM dosage. So this would be an aqueous injection, which is developed by encapsulating this progesterone in the cyclodextrin, which increases its water solubility. And upon entering the body, the cyclodextrin gets readily digested, liberating the free progesterone. So advantages, the injection is a bit less painful because it's not oil based. So patient compliance is a bit more. Okay, so coming to this vaginal progesterone, what does it do? So according to Fertility Sterility 2012, the endometrial level, that is the tissue level, is with intravaginal progesterone is much better compared to intramuscular. And in case of IM, progesterone is also highest serum levels. So IM, it has a highest, the blood concentration is more compared to the intravaginal. So they say vaginal is much better, but again, compliance of the patient is also very important. So for ideal LPS, IM progesterone for the highest serum levels and vaginal progesterone for increasing the endometrial levels until placental progesterone production is adequate till around 8 to 10 weeks of gestation. So I've just put a table here which compares all three. So when it comes to oral, it's an easy route, but micronized form only 10% is absorbed, so it's not very effective. And side effects are also sedation and hypnosis. Coming to intramuscular, only disadvantage is that it is oil-based and it's very painful. So patients don't find it difficult to take. So there is non-compliance, but it gets rapidly absorbed and the level is maintained for 72 hours. Coming to vaginal, here it is a targeted organ delivery. So high concentration will be there in the uterus and the endometrium, and that first pass hepatic clearance is there, and first uterine pass effect. Systemic side effect is less because it passes, it does not go into the liver, and patient compliance is also better because it's less painful, and also they can self-administer. So coming to the dydrogesterone. So this dydrogesterone is actually a very good form of progesterone, which we give it in a day-to-day clinical practice. It has a good oral bioavailability, which has an anti-estrogenic effect on the environment, causing a secretory transformation. Selective progestational activity, better bioavailability and metabolic stability. Better tolerated. Orally, it is active even at a low dosage. So mechanism action, it's similar to the molecular structure and pharmacological effect as that of the endogenous progesterone itself. And it mimics the action of endogenous progesterone on neuroendocrine control of ovarian and endometrial function. So it is a category B. How do we give it? 10 mg twice a day for 15 days. So usually we'll check for the ovulation and then we'll start with the progesterone. And advantage is easy to use, patient compliance is better, oral administration, and evidence-based also. I have just put across two studies where Chakravarti et al. 2005 a prospective randomized study compared the efficacy of the vaginal micronized progesterone with oral dydrogesterone as luteal phase support after IVF. So they saw that they had similar rates of successful pregnancies, but maybe the dosage what we use in case of micronized would be more compared to that of the dydrogesterone as a luteal phase support. So coming to relatively retarded endometrial development in artificial cycles treated with oral dydrogesterone has been reported in several studies. Oral dydrogesterone might be sufficient for luteal phase supplementation even in IVF cycles. However, we need more RCTs before getting into a conclusion. So coming to this Cochrane review 2011 reported clinical evidence in favor of dydrogesterone for luteal phase support, no enough evidence to confirm that the drug produces congenital defects. So coming to the side effects of this progesterone, again, breast enlargement, breast tenderness, constipation, GI upset, bloating, somnolence, headache, depression, discharge PV with vaginal progesterone. So other forms of luteal phase support coming to HCG. So progesterone and estradiol are hormone supplementations, whereas HCG is used to stimulate these hormones in the corpus luteum. So placental protein 14 and relaxin concentration, which has been shown to increase at the time of implantation, they're higher with the HCG support. But limitations are there because HCG will cause ovarian hyperstimulation syndrome. Luteal support with HCG should be avoided if the E2 level is more than 2,700, if the number of follicles is more than 10. Coming to administration, administration of HCG stimulates the corpus luteum to produce the progesterone only in the situations when the LH receptor population is inadequate. Hence, it will be ineffective in certain circumstances where direct progesterone supplementation itself is more efficient than giving HCG to increase the progesterone levels and to improve the luteal function. So which is better? Progesterone is as effective as HCG for luteal phase support, but safety, when we see, we will definitely choose progesterone compared to that of HCG, dreading the ovarian hyperstimulation syndrome. So coming to all the adjuvants now, low dose aspirin. So what does this aspirin do? Vasodilatation and decrease in the platelet aggregation, increased ovarian and endometrial blood flow, ovarian responsiveness, endometrial thickness, decrease uterine contraction at the time of embryo transfer. So low dose aspirin doesn't improve the ovarian responsiveness, blood flow, and pregnancy rate. Definitely, as evidence based, low dose aspirin is not recommended, but in clinical practice, we are definitely using it because this does not have much of the side effects. So some advantage if we get, it is good enough. So we do use low dose aspirin empirically. Then coming to the GnRH agonist. So this GGIRHR agonist also nowadays we are using it for luteal phase support. So how do we go about that? So this GnRH agonist was recently suggested as a novel luteal phase support that may act at different levels, including the pituitary gonadotropes, the endometrium, and the embryo itself. Regimens for IUI would be single dose of triptorelin 0.1 mg 6 days after ovulation, or 3 doses of lupride 1 mg subcutaneously 6 days after ovulation. Coming to natural cycle, again, no treatment for luteal phase insufficiency has been shown to improve the pregnancy outcomes in natural unstimulated cycles. So when we do an ovulation induction, then improved pre-ovulatory follicular dynamics should improve the corpus luteum function. Use of agents that induce ovulation improves the corpus luteal function and fertility outcomes. So this is one study where there is progesterone which is used for ovulation, that is ovulation induction and intrauterine insemination. So in this study, again, the evidence says that we have to use it only for IUI than for the CC or Letros stimulated cycles. So coming to the cycles that is in IUI. So when we use a gonadotropin for an IUI, what happens is at the level of the ovaries, the E2 levels will become high. So because of that, there will be a negative feedback on the GnRH pulses. So the evidence will says that pregnancy rates are statistically significant in the LPS group compared to that of without the LPS. This is according to Fertility Sterility 2017. So again, in clomiphene citrate, IUI cases, what happens? It acts on the hypothalamus, already discussed. It blocks the E2 receptors, loss of the negative inhibition, increase in the GnRH and LH pulses, which favors the luteal support. So generally, we don't require in case of CC. No statistical significance difference in clinical pregnancy rate with and or without luteal phase support. With Letros, the clinical pregnancy rate was 23.2 with progesterone, 12.5 without progesterone. So we are giving empirically even with Letros, even though the studies don't suggest that it is required when we are giving with Letros. LPS in IVF and FET cycles. So how important is this luteal phase support when it comes to IVF and in case of FET cycles? So what really happens in these cycles is that in ART, estrogen pretreatment has a role in priming the endometrium, that is in HRT, FET cycles. Due to the lack of endogenous estradiol production, there is inadequate endometrial priming impacting the embryo implantation. Forms like the oral estradiol valerate hemihydrate 4 to 8 mg per day as a starting dose is what we give. It has high first pass effect, hence cautious use should be done in patients at risk for this VTE, vascular thromboembolisms. Okay. Then transdermal preparations like gel or patch, especially in patients at risk of VTE, found to be less effective in hot and humid weather, also in obese patients due to less absorption. Cochrane review 2015 suggests that there is no conclusive evidence of difference between patients using either progesterone alone or progesterone with oral estrogen when it comes to clinical pregnancy rate and ongoing pregnancy rates. So what are the timing for this LPS? In ART cycles, there is endogenous production of P4 starting after the HCG trigger. Correct timing of LPS in IVF cycles is crucial. If given early, it will cause the advancement in the endometrial maturation, making it out of sync with the growing embryo. Administration of IM progesterone prior to oocyte retrieval compared with 24 hours post the retrieval will result in lower pregnancy rate. So, LPS in the IVF cycle, that is fresh transfer cycles with agonist trigger. HCG bolus, that is small bolus of 1500 IU after agonist trigger, gives similar pregnancy rate as compared to HCG triggered cycles without increasing the risk of OHSS. Recombinant LH in a small study, it was used in doses of 300 IU on alternate days starting from the day of oocyte retrieval along with daily progesterone. Though similar pregnancy rate was seen with recombinant LH as luteal phase support in GnRH agonist triggered cycles as compared to HCG triggered cycles, limiting factor is high associated cost. Also, larger studies will be needed before we can put it into practice. And intensive progesterone and estrogen support for agonist triggered cycles is important compared to that of the HCG trigger. The most optimal LPS post GnRH agonist trigger remains to be found, although many modified LPS protocols have shown promising reproductive outcome. So how long should we give this support? Prescribe for 15 days. If pregnancy is negative, we stop it. If the pregnancy is confirmed, we continue to 7 to 9 weeks with gestational age, that is till the luteoplacental shift occurs. So even till 10 to 12 weeks also, we do give till the shift happens. So depending upon the scans as well. So most of the centers, we prefer to continue till 10 to 12 weeks of gestation. So LPS in natural FET cycles, P4 support improves the implantation rates in fresh embryo transfer cycles as well as HRT FET cycles. In a large study by Sun et al., the Fertile Sterility 2017 tells us that involving 1,158 frozen thawed 80 cycles, it was concluded that vaginal progesterone supplementation significantly improves the pregnancy rate in natural FET cycles. This may be due to suboptimal endogenous production of progesterone in patients undergoing ART. So, I wanted to give some take-home messages, that is regarding the ART, why it is required, that is the luteal phase support. So when you come to ART, why is it that it is important? One thing is, if we are giving when we start an ART cycle, what happens? From day 2, when we stimulate the cycle, gonadotropins we give, and then either it will be an agonist, that is a long protocol, or it could be an antagonist protocol. So when we are giving these medicines, that is these injections, mainly to suppress the LH levels. So when we suppress these LH levels, what happens? This basically prevents the premature LH surge. So when the premature LH surge gets suppressed, definitely it will affect the luteal phase as well. So for that, the levels of the LH will be suppressed for that one reason. Next would be in control ovarian stimulation. What is the other thing which we see? The estradiol levels. The estradiol levels will be high. So again, that will suppress the LH levels. Then even if we give an HCG trigger, that also lasts only for 3 to 4 days. So, and when we give an agonist trigger, that is even more shorter. The mechanism itself is shorter. It will lead to a luteal phase defect, which we need to give extra luteal phase support when it is an agonist trigger. And one more thing, what we do in these cycles is mainly we are aspirating the follicles to retrieve the eggs. So when we aspirate the follicles, we are not only aspirating the egg, but also the granulosa cells. So these granulosa cells are also required for the LH in our body to act on the granulosa cells, thereby to produce more estrogen and progesterone. So these things are the reason why it is very crucial for us to give the luteal phase support. So apart from that, if there are any questions, I would like to take them now. Thank you.
Thank you, ma'am. Thank you for your depth of knowledge for the topic is great source, ma'am. We are grateful for the knowledgeable talk, ma'am.
Thank
And
you.
we do have questions in the chat, ma'am.
Yeah.
Role of HCG in FET cycles, as there no
So FET cycles, as in from the beginning of the stimulated cycles, or are they asking for the pregnancy? When it becomes pregnancy positive, it depends, because see, in FET cycles, there is no corpus luteum. So artificially only, we are giving all the luteal phase support. So we do add, as in on a weekly basis, depending upon, and also we continue it post pregnancy as well. So HCG does help as a luteal phase support. So the dosage we change. So in case of an agonist trigger, so what would be the dosage is, we can give, so why do we give this agonist trigger is, so that this OHSS doesn't happen. But we can give HCG for, a minimal dosage, but it is difficult to, dissolution of this HCG is quite difficult. But there are studies which, where we have given, like we can give on the day of oocyte retrieval 1500 IU. So this also will help for the luteal phase defect which has occurred because of the agonist. Or some people give even 500 international units of HCG. Every 2 days we can give for 3 doses. So that also helps. Some people give recombinant LH, that is 10,000 IU daily, but it's very expensive. Clinically, we cannot, and patients are not very affordable for us to give this recombinant LH. And apart from that, one more thing is HCG, which is given as 125 IU daily, we'll give till the pregnancy test. So these are the ways which we combat the luteal phase defect when it comes to agonist trigger, because we do not have an option when, in PCO patients, we cannot give them we can give dual, but again, the risk is very high if the E2 levels are also very high. So that way, HCG as a luteal phase support is very helpful.
And we do have 2 more questions, ma'am.
Sure.
I think there are 3-4 more questions, ma'am,
Okay.
which you can answer.
Yeah.
Questions, ma'am.
Okay. So how does the LH surge affect on PCOS? So PCOS itself is a questionable thing, because see, not all PCOS patients will have a deranged LH level. So when we see, there are some studies also where the basal LH level is also seen. Like for example, on day 2, when we see the LH, some of the PCO patients, that is like the classical PCOS, they'll have a very high LH level. So because of that, we generally suppress them. So only if we suppress that, the follicle tends to grow. Otherwise, the follicle, if there is a premature LH surge, the follicle will, the follicular genesis will be disturbed. So because of that, we will suppress the LH. So in PCO, definitely we need to give more luteal phase support. And according to LH surge, naturally, we do not really get, because if it is an ovulatory PCOD, again, we need to see how the follicle has developed, whether if the follicle ruptures early, or how the LH surge has happened. So when we are monitoring, that is when with the follicular monitoring, generally we give the trigger itself, right? So in case of monofollicular, for example, in IVF, the stimulated cases, we mostly go for PPOS protocol, or we'll be giving a the ANTAC protocol. And most of the time we avoid the HCG trigger. So that way, that's how it works for PCOS. IVF after 6 months, I didn't understand. 6M meaning? What is this? This question, no? Rajeshri Banerjee has asked IVF after 6M. What does that mean?
Ma'am, that question was
Okay,
has already answered, ma'am.
Okay, sure. So there's
Below
one.
that, you have 2 more questions, ma'am.
Yeah,
Also,
how do
I
you
have a,
diagnose the patient with PCOS?
which protocol you use, madam, and from Rajeshri Banerjee.
Okay, sure. I think I've gone way back, no? Which protocol do you use for? What is it? For TB, no, this is, I think, for Dr. Shubha. Which protocol do you use, madam? It was for TB. I don't know. It's not for me. In cycle, progesterone is given from 16 to 25 days as a practice. Can we continue it till the patient is positive and then continue up to 9 to 10 weeks? Yeah, we can. That's what I said. No, see, this CC cycles, they actually don't require progesterone, that is luteal phase support, because we're not disrupting the actual mechanism which is happening. But sometimes what happens, the patient response is also important. So sometimes the E2 progesterone ratio changes because we're manipulating. Sometimes because of the HCG trigger for us to create an LH surge for ovulation, that also has an impact. So these things, which we call it as modified cycles or the stimulated cycles, mild stimulated cycles. So for these also we can give luteal phase support. And usually when we are giving electrodes, we'll monitor through the scan. So post ovulation, we can start the luteal phase support and continue it till the pregnancy test, which is positive. And further, we can continue till the luteal placental connection starts. So that way, as you said, 9 to 10 weeks or even 10 to 12 weeks is also fine, depending upon the patient. 9 to 10 weeks is also good enough. If everything, the scan, usually we see till the NT scan. And sometimes we taper it till 12 weeks and stop, or we stop it at 12 weeks.
Thank you so much, ma'am. Thanks for answering all the questions, ma'am.
Any other question is there? I'm actually not able to see properly. FET, progesterone can be given till pregnancy test as LPS. Yeah. How does LH surge affect PCOS? That I answered. Also, I have a doubt, person who has PCOS but regular cycles, and from past 2 months, there's no proper cycle. So what is your advice? So advice would be the patient has to, check with the hormones, that is, see for other things also. See, some patients might be self-diagnosed also. So if it is really PCOD or whether there is any thyroid issues or any hyperprolactinemia, that has to be checked. Then apart from that, what are the other things which has changed, like with respect to the lifestyle? Sometimes they might have exercised properly or the diet would have been different. So even these minor changes contribute to the cycle regularities. So main thing would be to get a baseline scan and see the ET level thickness, and depending upon that, give a withdrawal, and post that monitor. Like if, depending upon the married life also, better to, see whether immediately, like you just do a follicular monitoring with or without ovulation induction and move forward. So that would be my advice for this patient. That's it, right? I think. Any other questions?
Ma'am, thank you, ma'am. Thanks for answering all the questions, ma'am.
Thank you
And
very much. Thank you for the patient listening to all the participants.
it was very kind of you, ma'am. And next, kindly start answering for the display questions. Every question will have 30 seconds will be given. So please start answering the questions one by one. And the first answer is option C, progesterone. Participants, everyone can answer the questions right. For the second question, the correct answer is option D. And the next question, for the third question, the answer is option D. For the fourth question, the answer is option C. Now GGIRHR is open for admissions. Kindly contact us to the displayed number and to our website also. And if you have any doubts, you can call this number and contact us. Finally, I would like to conclude today's CME. I extend my gratitude for speakers who gave us insight in the field of infertility. And I thank all the participants in making this webinar a successful event. Next CMA is on May 21st. For further courses and details and admission process, you can contact GGIRHR. It's www.ggirhr.com. And thank you, everyone.